Hello, hello. Welcome to part 1B of the circulatory system with a focus on blood. This is chapter 18. When we were discussing hemoglobin in part 1A, I completely forgot to mention that the reason that blood is red is because of this relationship between the red blood cell and the heme group on hemoglobin. So I definitely want to just kind of take a quick minute and discuss this before we keep going with our original discussion. So over here I wrote for you, why is blood red? And it turns out that the minute the red blood cell gets attracted and attaches to the heme group on hemoglobin, it actually develops the red coloring. And the higher the attraction or the more red blood cells you have attached to heme groups, the brighter red the color becomes of your bloodstream. So below in the insert, you can see they have a little chart, and as you're looking at the coloring within the boxes, the red starts to darken as you move from left to right, and that's a really good indication of how the patient is doing with its hemoglobin concentration. The darker the blood is, the more hemoglobin it has, and the more the red blood cells are attaching themselves to the heme group. And this is also one of the reasons why when you're studying your blood vessels, we're going to come across arteries and veins. And you're going to notice that with arteries, they always tend to use the red coloration. And that's because arteries carry oxygenated blood, so blood that's filled with O2 molecules, whereas veins carry deoxygenated blood, very low on oxygen but high on carbon dioxide. And in fact, for some of us, we can look through our skin and we can actually see our veins, the blue lines kind of peeking through. So the question then is, how come I never see blue blood? Why is it every time they draw blood out of me, it's always red? Well, the minute the needle punctures the skin, it actually introduces oxygen into your blood supply, and that is then why it turns red. Fun fact, huh? Alrighty, so let's go back to our red blood cells. So we talked about erythropoiesis, we talked about that they live about 120 days, we talked about the process of filtering them out and getting rid of the hemoglobin, the heme, and the iron. So let's take a look at some of the erythrocyte disorders, and then we're also going to take a look at blood typing. So let's start off on the high end. If you have too many red blood cells, this is labeled polycythemia. Polycythemia can be caused by two reasons. Actually, it can be caused by many reasons, but it's categorized as either being caused by cancer or anything else. If it's caused by cancer, then usually we see that it's classified as what we call primary polycythemia. And in primary polycythemia usually indicates that the patient has cancer within its red bone cell, which causes the reaction rate of erythropoiesis to increase dramatically. As you can see, we've had reports of patients having a hematocrit of 80%. That's almost double what it normally should be. Secondary polycythemia is when you have high levels of red blood cells that are caused by anything else besides cancer. A lot of times, secondary polycythemia is something that is temporary. So it could be due to a lifestyle change, like maybe you have go through periods of dehydration, you went and you moved somewhere where you have a higher altitude, or you switched up your exercise and physical conditioning routines. We also see it in patients that have some respiratory issues, such as emphysema. Either way, what we see happening is that in secondary polycythemia, you will also have an increase in your red blood cell production, but it will be not nearly as high as if you have primary polycythemia, which is only caused by cancer in the red bone marrow. One of the main issues with polycythemia is that if you start filling your blood vessels with red blood cells, you're basically putting a lot of strain on it, and you're increasing the blood pressure and thereby also increasing the strain that you put on the heart, and it has to pump and flow the red blood cells from point A to point B. This pressure can cause the patient to develop an embolism, which is that they get an obstructive blood vessel because of a blood clot that has come off and kind of blocked the flow. Patients can also suffer from stroke as well as heart failure. Anemia is going to be at the opposite end. So anemia can describe many different things. I know a lot of people think anemia means I'm very low on iron, which is actually the most common issue with anemia. So your body notices that it's in a hypoxic condition, it produces more red blood cells, but it doesn't have the ability to carry the oxygen to its full max because it's missing iron. So when you see that happening, then you fall under the category of iron deficiency anemia. And that basically means that yes, you have enough red blood cells, but you don't have enough functioning hemoglobin. You can also have cases where you're not producing enough red blood cells, and that would also be considered anemia. This would happen, for instance, if you're very low or not producing any EPO. We also know that there's pernicious anemia. This tends to be an autoimmune disease where your stomach tissue stops doing B12 absorption, which is an essential vitamin that we require for DNA replication and red blood cell productions. We also see that there is what we call hypoplastic anemia. This is when the erythropoiesis process will dramatically slow down and the patient will just naturally produce less and less red blood cells. We also have aplastic anemia, which means that the erythropoiesis system will completely shut down. This can be caused by cancer, or this has also been shown in cases where the patient has been exposed to abnormally high levels of chemo and radiation, creating this nasty side effect of the red blood cell, of the red bone marrow shutting down erythropoiesis. You can also lose a massive amount of red blood cells if you're hemorrhaging. So if you, for instance, get into an accident and you lose a massive amount of blood. And then we also have what we call hemolytic anemia. And this is then when your red blood cells that you have floating through your blood vessels will go ahead and get destroyed in a high quantity. And we see this, for instance, that certain drugs, certain poisons, certain amounts of radiation can cause this. But we've also seen this happen in patients with sickle cell, that the disease, because of the sickle format of the red blood cell, will cause clumps of red blood cells to be destroyed, thereby lowering their ability to carry oxygen. The take-home message is that when you see anemia, please keep in mind that it's due to either having low red blood cells or it's due to having low hemoglobin within those red blood cells that you are producing. Either way, you are often in a hypoxic condition, meaning that your body is not getting enough oxygen. So here's just a little slide that I inserted to kind of show you the main symptoms of anemia. The patient will often come in and complain that they are very lethargic. Oftentimes their skin will be paler, meaning that it's lighter than normal. Part of that is because our skin tone actually also gets some mixture from our red blood cells. So if you're producing less red blood cells, usually there is a lighter tone to the skin. The tissue will also have more hypoxia, meaning low levels of oxygen. We also notice that the heart rate will tend to be a little bit higher with a lower blood pressure because of the low viscosity that's occurring with anemia. For many of us, if we're anemic, it's due to our iron deficiency. So in that case, that's an easy solve. We can go ahead and go and buy over-the-counter iron supplements, or we can increase our food intake of green leafy vegetables, such as spinach. Or if you're a fan of liver, liver is actually a really good way of getting lots and lots of iron inside of your body. Another disease that you come across with red blood cell is sickle cell disease. Now, sickle cell disease is a hereditary disease, and what we see happening, it's caused by a one nucleotide mutation. So if you were to take the genotype of someone with sickle cell and you were to kind of see their adenine, thymine, guanine, and cytosine, what would make them different is that they have a mutation on just one amino acid on their beta chain. And the changing of this one letter is what causes the disease. In sickle cell, what we see happening is that the red blood cells will become more of a crescent moon shape. You can see it on the insert of the picture on the top right? And as the cell becomes sickle, it becomes very sticky, and the red blood cells, instead of flowing freely through the blood vessels, will actually start to clump together. And as they're clumping together, there's a few things that's happening. First, you are blocking your smaller blood vessels, but also you're not able to move your gases in a normal pattern. So patients will often have issues with hypoxia, and they'll also notice that they have polycythemia because your body will respond to the low levels of oxygen by producing more red blood cells, not realizing that the red blood cells have a combination of a normal as well as a sickle shape. Oftentimes we see that patients will suffer from kidney and heart failure. They're at a higher category of developing stroke. They'll have lots of joint pains. And we also see that often they'll have enlargement of the spleen and the bones of the cranium, as those tissues will revert back to erythropoiesis because they're trying to give the body more red blood cells to combat the chronic hypoxic condition that it's in. Now, sickle cell is what we like to call a homozygous disease, Homozygous means that you need to inherit both recessive alleles, meaning both mutated versions from your parents, in order for you to have the disease. So both mom and dad need to go ahead and give the mutation to their child. If the child only receives one mutation from the parent and they're heterozygous, so they have one quote-unquote normal copy of hemoglobin and they have one copy of the mutated sickle cell hemoglobin, what we see happening is that they do not have the disease. They are simply a carrier, and as a byproduct, they actually become resistant to malaria. So in order for you to develop sickle cell, you need to inherit it from both of your parents, but also keep in mind that if you have one copy of the mutation, you are a carrier, you do not have a disease, but it does increase your chances of your offspring developing disease, especially if your significant other also carries the trait. Now, I hope all of us know our blood types, and if you don't, the next time you visit your doctor, or even if you go to donate blood, they'll be happy to tell you. It's very easy to determine your blood type, and blood types are done many different ways. In the United States, we rely on the ABO blood system, and this is determined based on little antigens or receptors that you find on the cell surface of your red blood cells. Now, please take a look at the bottom of the slide. And what you're going to notice is that instead of saying antigens, you can also say agglutinogens. Notice how both terms end with G-E-N-S. So if you come across agglutinogens or antigen, it's the same thing. It refers to the little receptors that sit on top of your red blood cells, and they will be the ones that determine what blood type you have. In your plasma floating around, so the liquid part of your blood, you will have antibodies. Antibodies are also referred to as agglutinins. And your antibodies will protect your system from what they do not know. So they will protect you from foreign antigens or agglutinogens. And when they come across a foreign antigen, it will cause agglutination. So at the bottom of your slide, I wrote down that an antigen and an antibody, when they combine, will form agglutination. And agglutination means that we're going to be clumping together the cells. So it will clump together the red blood cells. And this will be a way to kind of alert the immune system that there is a foreign antigen floating around. All right, so when it comes to our ABO blood typing, what we see happening is that we're going to take a look at our agglutinogens, our antigens, on top of our red blood cells. And we see that we have three variations. You can either have an A antigen, a B antigen, or an O antigen. And what makes the antigen different will be from what type of sugars they're composed of. So you can see on the little insert right there, it shows you the chemical structure of A, B, and O. Now, it's not that important to know what sugars goes with what antigen. Instead, what I want you to know is that A and B are co-dominant. So they are the dominant genes. As long as you have one copy, it will show through in your blood type. O is recessive, And in fact, O is called the naked antigen because your body has lost the ability to detect it. So your red blood cells can still carry that antigen, but your body won't be able to see it or read the O antigen. Now, in a perfect world, what's going to end up happening is that you'll have your agglutinogens on your red blood cells, determining your blood type, and you'll have your antibodies or agglutinins floating around in your bloodstream, protecting you from what you don't know. So in a little bit, we're going to talk about how you have antibodies against A, antibodies against B, but you don't have any antibodies against O. And the reason for that is O is the naked receptor. If your body can't detect it, it won't be able to produce an antibody against it. So here's an example of a laboratory experiment that we could conduct. If a patient comes in and you want to figure out what their blood type is, what you can do is you can just go ahead and you can collect a blood sample, and then you can artificially expose them to antibodies. And if the antibody is a match to the antigen, you'll have agglutination, you'll have clumping. So for instance, if you take a look at the picture right here, you can see that our first set is if you have a type A blood type. Type A means that that person has at least one A antigen or agglutinogen, which means that if I mix it with antibody against A, I'm going to get agglutination. And that's why in my first circle by type A, I see little clumps of red. That's agglutination. Now take a look at the circle that's underneath the anti-B and notice that the blood is just nice and liquidy. And that's what you normally see inside your body. You will never have a match between your antigen and your antibody because you don't want your blood to clump. You want it to stay nice and fluid. So you'll only produce antibodies against what you do not know. So if you're type A, you know all about the A antigen, but you don't know anything about the B antigen. So you have antibodies against B. If you're type B, that's the next step. Notice how if you introduce type B with antibody for A, it stays nice and fluid, mismatch. But if you do type B with antibody for B, you get the clumps, agglutination. If you're type AB, then you have antibodies for nothing because you know what A looks like and you know what B looks like. So in my artificial stimulation, you could see that if I take my patient with type AB blood and I mix it with either antibody A or antibody B, I'll get agglutination. And what about if you're type O? If you're type O, you have no receptors, so there's nothing for the antibodies to react with. So what we're going to see is if I mix together my antibody A and my antibody B, they won't be able to detect any receptors, so the blood stays nice and liquidy. Now, it turns out the most common blood type in the United States is type O, meaning they have the naked receptors, and the rarest is type AB, meaning that they have receptors for both A and B. In case you were wondering where exactly do these antibodies or agglutinins come from, well, your body naturally starts producing them after birth, around 2 to 8 months after, and usually by the time you get to about 10 years old, you have your highest titer of your ABO blood concentrations. And a lot of research has actually shown that we produce these antibodies initially in response to some of the bacteria that we have in our gut. And somewhere or another, it also matches or it mismatches the blood types that we are exposed to. Now, I'll show you a chart in a little bit, but you always want to keep in mind that your body will never form antibodies against their own antigen. So if you're type A, you don't form antibodies against A, you form antibodies against B. If you're type B, you form antibodies against A. And what we see happening is that the classic definition of an autoimmune disease is when those signals get crossed and your body starts producing antibodies that will directly attack your own antigens. This would then be an autoimmune disease. In a perfectly working system, you do not produce antibodies against your own antigens because you don't want agglutination to unnecessarily occur. And agglutination, like I mentioned to you before, is when you have a match between your agglutinogen and your agglutinin, your antigen and your antibody, and it will clump together, this match. In the case of our red blood cells, if agglutination occurs, we see that the red blood cells will form a huge clot, and that will inhibit the blood flow, and it will oftentimes block a lot of our smaller capillaries, which can eventually cause kidney failure, and it could cause death. It all depends on how much of mismatched blood was transfused into the patient and how long it took for the error to be detected. So in this little illustration, you see an example of agglutination. If you look on top, you notice that there's a needle that shows that blood is being given from a type A donor, and the patient is actually type B. Since the patient is type B, that means it has B agglutinogens or B antigens, which means that the antibodies are the opposite, so it produces antibody A. This then means that if you give that patient type A blood, the A antigens will be detected by the antibodies for A, and you'll get agglutination. So towards the left-hand side of the image, you see how the red blood cells start agglutinating or clumping together, and how they're also blocking your smaller blood vessels. I think this chart is a really nice idea to kind of summarize blood typing. So as you can see right here, if we start on top of the chart, it says that the blood types that are out there, according to our ABO system, is that you can have a patient that has blood type A, B, AB, or O. Now remember, A and B are co-dominant, so they're always going to make an appearance in your blood type. O is recessive, so the only way you'll be able to have O blood is if both of the copies you inherit from your parents are type O. So go ahead and take a look at your third row, and it says antigens in your red blood cell. So these are your little receptors, your agglutinogens, and it says that if the person is type A, they need to have at least one A antigen. So your options are either that one parent gives you an A and the other one gives you an O. Remember, O is recessive, so it's hidden, or both parents give you an A. So your homozygous AA or your heterozygous AO. Same thing goes for if you're type B blood. You're either BB, both parents gave you a B, or you could be BO. One parent gave you a B, the other parent gave you an O. Remember, the O gets ignored, especially if you already have a dominant one, an A or a B. If you are blood type AB, then you automatically know that one parent had to give you an A and the other one had to give you a B. And if you're blood type O, that means that both of your parents gave you the O. So on the chart, I know it says none, but there are O antigens. Your body just loses the ability to read them. So as far as the body is concerned, there's nothing there. It's the naked antigen. Now, above the antigen, it says, what are the antibodies that are in the plasma? And remember, we produce antibodies against what we do not know. So if you're blood type A, you have an A antigen, which means you don't know anything about B. So you have antibodies against B. If you're type B, you have antibodies against A. If you're AB, then you're familiar with both sets, so you have no antibodies. Now, what if you're saying to me, but what happened to O? Why am I not producing any antibodies for O? Well, remember, your body can't detect O, so if it can't detect it, it won't be able to produce antibodies against it. Last one is if you're type O, you have no detectable antigens, which means that your antibodies will be both against A and B. Now, this then turns out that we can determine blood typing when it comes to blood transfers. And the golden rule is that you can always receive your own blood type, and you can always receive O, because O is the naked red blood cell. Your immune system won't detect it. So at the bottom of the graph, it says, if you're blood type A, you can get A or O. I cannot give you type B because you have B antibodies. That's going to cause agglutination. If you're type B, you can get blood type B and O. I can't give you A because you have antibodies against A. If you're blood type AB, well, you're the life of the party because I can give you AB, I can give you O because everybody can receive O, and I can also give you A and B individually. And if you're type O, you're in trouble. Well, not really. Because if you're type O, since you have antibodies against both A and B, your only option is to go ahead and receive O blood. Any other type will cause agglutination to occur. This then explains why the universal donor is type O, because it has no antibodies, which means, it has no antigens, my apologies. Type O has no antigens or agglutinogens, which means you can give it to any and all patients. The universal recipient, the one that's able to receive all the blood types, will be blood type AB, and that's because it lacks any of the antibodies, so it's able to receive AB, O, A, and B by itself. Now, the story of blood typing is not done yet, because any of us who know our blood type know that in addition to knowing the letter, we often also indicate a plus or a negative. So for instance, my blood type is O negative, but some of you might be A positive. So what exactly is the positive and the negative? It is a completely different set of antigens, also found on the red blood cell, but we call these the Rh antigens. And they come in different variations, but the one we care about is the D antigen. So Rh is named for the fact that it was discovered in the rhesus monkey. And the variations are C, D, and E, and the one you care about is D. So the D antigen is what humans have, and the way it's going to work is as long as you inherit one D antigen, you're going to be considered positive. So you could either be positive, meaning both parents gave you the D antigen, or you can be positive, negative. Only one parent gave you the D antigen. And something, if you're going to be negative, so I'm O negative, the negative means that neither parents gave me the Rh or D antigen. So I didn't get any of those particular receptors. So positive means you either get at least one or you get 2 copies of the D agglutinogen. Negative means you inherit nothing. And a really cool thing about the Rh group is that your body will not produce antibodies against the D antigen or the Rh antigen unless you become exposed to it. So what does this mean? Well, first off, keep in mind that if you're positive, so you have the antigen, you will not need to produce antibodies against it because you know what it looks like. If you're negative, your body will only produce antibodies against it or agglutinogens against it if you become exposed to it. So for instance, if I take my O negative blood and I now go to the hospital and say I need a blood transfusion, and they make a mistake and they give me O positive blood, my body is going to recognize the positive as being foreign, but since I'm not born with antibodies, there'll be absolutely no reverse reaction. On the other hand, the next time I go to the hospital and I now go ahead and get more O positive blood, my body will have had time to produce antibodies and I will get the agglutination process just as if they had mismatched the letters, so if they had gotten me A or B blood. So you'll only start developing antibodies when you become exposed to the Rh antigen. And the first time you become exposed to it, there's no consequences because we don't have those antibodies readily available. And in fact, what we can do is we can go ahead and we can take a look at this disease called the hemolytic disease of the newborn. It's also called erythroblastosis fetalis. That's a whole wordful. So hemolytic disease of the newborn is what we're going to keep calling it. This happens when you have a mother who is Rh negative and she carries a baby that's Rh positive. Now, this can happen because remember, in order for you to be Rh positive, all you need is one Rh or D antigen. So if Dad gave you one, then the baby will automatically be Rh positive. Now, the first pregnancy, there's no issue, but any pregnancy after that, the body will start detecting the foreign Rh receptor, and mom's antibodies will be able to cross the placenta and start attacking the baby's blood, which can cause massive agglutination and can be very detrimental to the fetus. I'm going to show you this in a picture in just 1 second. I just want to kind of point out towards the bottom right there that this is preventative, and there's a shot out there called RhoGAM that's given to pregnant women usually by the start of their 3rd trimester and right before they give birth, and the RhoGAM basically shields the baby's antigens from the mother's antibodies. Let me show you this in illustration and we'll talk more about hemolytic disease of the newborn. Okay, so here's mom starting on the left-hand side, first pregnancy. Notice how mom is Rh negative and the baby she's carrying is Rh positive. Now, the baby's blood and mom's blood are kept separate. However, during childbirth, whether you're doing a C-section or vaginal birth, there will always be a mix and a matching of mom's blood and baby's blood. And at this time, mom's body will detect the Rh positive antigens from the baby. So it will notice the foreign antigen. And in between pregnancies, what we see happening is that your immune system has plenty of time to produce these antibodies against the D antigen or the Rh antigen because, like I said, it was exposed to a foreign entity. If mom now gets pregnant for the second time and her baby is also Rh positive, those antibodies that she made in between her pregnancies will be able to cross the placenta and start attacking her unborn child, thereby causing hemolytic disease of the newborn. So there's no danger to the first child because the body doesn't have those antibodies ready to go, but there is danger to any child that comes after that, especially if the child is Rh positive. Now, this only affects Rh negative moms. If the mom is Rh positive, that means that the body already knows what the Rh receptor looks like, so there's no need to produce antibodies against it. So the baby, it doesn't matter if the baby is Rh positive or negative, there will be no harm from that particular aspect. So hemolytic disease only affects the mother if she's Rh negative and the baby is Rh positive, and it's only of danger to the second pregnancy on. So keeping that in mind, that means that we have to kind of adjust our universal donor and universal recipient notes because now we have to compensate for both the ABO type and the positive and the negative. So if you are positive, Rh positive, you don't care if the blood you receive is positive or negative because you know what the antigen looks like. If you're Rh negative, you have to be careful to only get negative blood. Remember, you get that one free play because you're not born with the antibodies. So it's okay for your body to become exposed to Rh positive blood once without any consequences. Anytime after that, your body will have developed the antibodies against it and you will get agglutination. So keeping this in mind, that would mean that our universal donor, the one who can give blood to anybody, is O negative because it has none of the ABO antigen and none of the Rh antigens. So that's a completely naked red blood cell, no reaction from the immune system. You can give it to anybody. But this also means that if you're type O negative, you can only receive O negative blood. If you are O positive, what blood can you receive? Hopefully you said, if I'm O positive, I'll be able to receive O positive. You could always receive your own, and O negative. Because remember, if you're positive, you don't care if the receptor's there or not. Your body knows what it looks like. The universal recipient, the one that will be able to receive any and all blood types, will be AB positive, because they can receive A, B, AB, and O, and they don't care if they're positive or negative, because they know what all the receptors look like. They don't have any of the antibodies against it. If you're AB negative, you can still receive all the letters A, B, and O, but all those letters need to be negative because your body does not know what the Rh antigen or agglutinogen looks like. Please make sure to review your blood typing carefully, and remember that you have your discussion sessions on D2L, and obviously I'm also available through email for any and all of your questions. I will talk to you soon as we start looking at our second part of Chapter 18.